a bit of the format today really originated as we had the meeting last year, where we found a bit as both a discussion as well as a chance to really take questions and go back and forth. We thought that much more helpful than just a very deep dive in terms of data. But our hope is, again, to really bring you up to speed on myelofibrosis. So Naveen and I, we're partners in crimes in many ways. We thought we would come in our beachwear here. Next year, perhaps, if we're at the beach, we rotate the venues here. But
they won't be Aaron. Not this week, they'll be hurricane.
Oh, yeah, right.
But again, as I like to say, when we're battling diseases like this is a team sport.
Right.
And we all play an incredibly important part in this. Yourselves as patients, patient advocates, again, you really help to drive the conversation in terms of what's important, what to expect, driving innovation in not only clinical trials, but how care is provided. The efforts of Anne and her team here really in terms of education and advocacy that, again, can have many different components. So we're going to break our discussion. We've got a couple just prompt slides. We're going to talk a little bit about diagnosis, burden, risk, and again, you've heard it in the ET and PV and myelofibrosis. It overlaps, but it's a little different. How do we think about treatment today, but also where is treatment going? So first, diagnosing myelofibrosis. So let me ask my good friend Naveen. So when you see all these patients with myelofibrosis, what would you say are the different types of ways that it's been found? Usually someone's been diagnosed prior to coming to MD Anderson, although not exclusively.
Right.
But again, what sort of ways do people find out that they have myelofibrosis?
Thanks, Ruben. So it's actually important, and for many of you here, both patients and caregivers, there's a couple of different routes. It's not one uniform route. So one is, of course, you had a prior MPN. So you had polycythemia vera, ET, you've been followed along, and then up, unfortunately, now you've transformed to MF. That's an obvious route. Some of you have that. But a second and third are important now. The second one is de novo. You've walked in off the street and you have myelofibrosis. That group of patients is symptomatic. For example, Ruben himself is the one who pioneered the symptom score, which many of you know now. Fatigue, fatigue, fatigue. Maybe it's not just normal aging. Maybe it's something else. Night sweats, abnormal weight loss as an adult, et cetera, et cetera. So you've come in because of symptomatic reasons, blood counts are abnormal, somebody astutely did a bone marrow biopsy. But there's a third category, Ruben, that you and I are starting to see. Maybe it's because of more awareness, sessions like this, and led by you and others, which is somebody who you weren't thinking about MF, you were working them up for, quote, something else. It's usually anemia, for example. Unfortunately, maybe the diagnosis is delayed because you're thinking about it being a benign thing. Many of our patients, maybe some of you in the room, it was thought to be, well, it's time for your colonoscopy, so let's do that. Okay, then the anemia continues. Finally, someone does a peripheral smear or bone marrow biopsy. So let's include that as the third category, which is being worked up for something else. And then, my goodness, you come into our category. I think those are three ways. And then, of course, the fourth way you have to say is bone pain. Some people do have bone pain as the presenting symptom or sign. Maybe you went to an orthopedic or a rheumatologist, and then you end up seeing us. So maybe those are some of the pathways to our diagnosis.
So very, very helpful, Naveen. So a couple of things I would add in there. So first, going back to this issue of ET and PV to MF. So one, the change to myelofibrosis is a spectrum of changes as opposed to being a yes or no. So people say, boy, do I have myelofibrosis now, yes or no, like a switch, or again, like a pregnancy test. A pregnancy test, either you're pregnant or you're not pregnant. Myelofibrosis, much more subtle. And because of that, again, there can be a range, or not infrequently a delay, between someone who has changed from ET or PV to MF and that diagnosis of the change. So let's discuss a little bit some of those pieces, because they're different. People fall along that range. One, the bone marrow itself. So the bone marrow, the difference between ET and PV, really little or minimal scarring in the bone marrow. You know, normal individuals, if we do bone marrow, so the scarring is not necessarily 0, it's kind of 0 to 1, so it's not necessarily 0 is not the baseline. To having clearly increased scarring, 2 to 3. Second, there is a change typically in the blood counts. Patients with myelofibrosis, with that scarring, the bone marrow tends to be leaky. The bone marrow acts very much like a vineyard. You know, how does it actually work? It's like a vineyard where grapes grow on the vine, and when we make wine, we harvest the grapes when they're mature. In the bone marrow, the cells are growing on the equivalent of vines, and when they're mature, they get sucked up into circulation. They get released and they go into circulation. In myelofibrosis, one of the fundamental things is that connection between the grape and the vine is not working quite right. So you have cells out in the bloodstream that normally are not there. Myelocytes, metamyelocytes, blasts potentially, and other cells that tell you that there is a change from where it was before. So ET and PV patients don't tend to have those things in the bloodstream. Myelofibrosis patients do. So that's another kind of sign from the bloodstream that things have changed. The spleen becomes sometimes significantly enlarged. It can be a little bit enlarged earlier. Spleen normally the size of our fist, normally well up into the rib cage. If we can feel it clearly extending under the rib cage, we're more concerned about myelofibrosis. The symptoms. Patients can have symptoms across the board in MPNs, but there are certain symptoms that really are more concerning about a change. One, inadvertent weight loss. People are losing weight without trying. That doesn't happen. Most of us try to lose weight, and we still can't lose weight.
Something's wrong. Something's wrong.
You know, now, mind you, I've yet to have a patient that lost weight from MF who said, boy, I feel terrible, but I've lost some weight. So even pathologic weight loss, people are like, I'm looking pretty good. So that change, for me, is always a big red flag, Or, boy, I've been trying to lose weight for 30 years, but I lost 20 pounds, just kind of off the cuff. So that's a concern, because the body really fights losing weight. So that is a concern. The acquisition of bone pain.
Right.
The development of fever. Fatigue can be present across the board, although most people will say, boy, I've had ET for 20 years, and I've had fatigue, but boy, I feel clearly worse these last 4 months, that something has changed. And then finally, there are changes in terms of the genetics sometimes. Sometimes patients who had only had the JAK2 or only had CALR frequently will have more mutations. So you can see how complicated it gets, because it's not one of those things, it's a constellation of them. And because of that, there's a bit of a spectrum from the people that have started having myelofibrosis to the people that really have more advanced myelofibrosis. And we'll get into how that factors into the issue of then risk. How do we factor these things into really understanding kind of the burden of the disease? Now, one final thing, you've heard a lot of things that I mentioned and not that much about the bone marrow. I think that has the potential to evolve. Part of the limitations that we've had with bone marrows is that there are a few things that the human eye could discern. Degree of fibrosis, a little bit of how the cells actually look, and these other aspects of the disease have really grown. So again, I've heard, far from uniform, boy, do we do a bone marrow all the time? Do we do a bone marrow, once a year? Do we do a bone marrow only if things change? Part of the limitation is that the information we've been able to get from the bone marrows has been limited. And there are times patients can have some more scarring in the bone marrow, but they lack these other features I discussed, and they haven't really necessarily progressed quite yet. This is one area in particular where I think that AI actually will make an impact sooner rather than later. Because AI already is looking at many more parameters than the human eye could typically track. now slides are typically digitized. And again, many efforts to try to learn much more from pathology, whether it be bone marrow pathology from myelofibrosis or whether it be in other areas. Naveen, what are some of the things that you think diagnostically are evolving? You guys at MD Anderson are such leaders, and there's some really cool things coming out of there, especially in hematopathology and others. What are some things that you're excited about that may help us take better care of patients?
Well, Ruben, this is exciting. And I remember someone from the audience asking about AI earlier, so I'm glad we're talking about that. Quickly, I did want to add, I loved your comments about how someone can develop or acquire an MPN. We also want to add young patients in particular, which was a discussion earlier, can present with an unusual blood clot. Sometimes not just the usual DVT, deep vein thrombosis, or pulmonary embolism, but a blood clot in the brain, cerebral sinus area, Budd-Chiari. So unusual ways of presenting with an MPN, particularly as a younger patient. But for your question, I think there are 3 or 4 different areas now of, let's call them advanced diagnostics, I think is what you're asking about. AI is one area. So what that means is you've done a bone marrow, but the bone marrow patterns can be difficult. It was mentioned earlier, this MF1 to 3, we can get 20 pathologists in a room and they'll all come up with 20 different diagnoses for that. So for the pattern recognition part, I believe that we're going to be there in just a few years. But that's already once the bone marrow is done. Number 2 is using AI and language, they call them LLM, language learning models, and big data before the bone marrow is ever done. So can we take your blood sample and on that blood sample get as much or more information as the bone marrow in 2025? Maybe not now yet, but this is what some of our colleagues are working on. I think Dr. Elf nicely mentioned our colleagues, so that's Dan Royston and Adam Mead in the UK. So if you're interested in learning more about that, you can Google their names. These papers are all easily available now to look at. So non-invasive, or at least less invasive ways of looking at, can you make a complex bone marrow diagnosis from the blood? Now, 3 and 4 are important. Imaging. We haven't mentioned imaging yet at all here, right? So your friends, colleagues, family members with other cancers commonly will get CAT scans, PET scans, x-rays. How come we didn't mention that here? Part of it is because the bone marrow biopsy has been the gold standard, and also because our myeloid MPN diagnoses usually aren't made from those. You can get a hint maybe, but I will say that there's functional imaging that's being worked on. Can you get an injection and then get a PET scan that can then light up in areas where either the bone marrow is abnormal, cancerous, and then can you pair that with AI to give you information? I'm actually particularly excited about that. So you're talking about an even less invasive way to make a diagnosis. And then finally, team, these molecular mutations that we're talking about. It used to be that we had to convince you and me, can you just check a JAK2? Okay, that's been 20 years to this day, actually. So 2005 to now here. I think most of the community, knows about JAK2. Now we have to convince people to check CALR. That's a whole nother battle. And then MIPL, forget about it. Most people have never heard of that. But if we can at least get those 2 or 3 out there, but then these other 80 genes, ASXL1 has come up a couple of times, TP53, RUNX1, you may have heard some of this alphabet soup. I actually believe that if we can get those standard, so cost, availability, anywhere from the community hospital all the way to the academic, those other mutations may be able to help, first of all, diagnose, actually, because there's something called the triple negative that Dr. Elf mentioned, 10% of our cases. That means you don't have the big driver mutations. Some of those cases are hard to read, guys. Sometimes what's taking so long is the pathologist has to tell us if you have cancer or not. That's a big decision. So can we get AI, machines, can we get molecular mutations to help that? So I just want to put that as a 4th program, which is greater availability of molecular mutation. We call it NGS, next generation sequencing, where your insurance covers it without a battle, where it's available. Right, yeah, this is a wish list, right? He asked me what I wanted to see. And then that information can actually be usable both to the patient and family member, but it's also understandable to the doctor. Ruben, I think these things are not 100 years away. I think what we're talking about here is more like 5 to 10 years.
Wonderful. So let's move to talk a little bit about the burden of having the disease. Now, patients with myelofibrosis have a really wide range in terms of how the disease affects them. And they're very different individuals. There are individuals that can be young, there are individuals that can be older, there are some that have really significant challenges, and others who don't know they have the disease if you did not tell them. So all of that is part of a factor. You know, when I sit with a patient, you know, I share that our goal is to try to make the disease as invisible in your life as possible. So what does it mean to achieve that goal? One, you know, are we helping protect you from the disease becoming more life-threatening? Because if the disease, typically, if it doesn't progress from where it started, an individual will live out the rest of their lives as they would have otherwise. So really, progression is the villain for most people with MPNs. Two, we're protecting them against the risk of blood clots and bleeding. So that's a separate issue, but that's also, how are we protecting you from things that might happen? Two, how do we alleviate how the disease is affecting you in your daily life?
Right.
And for that individual who says, you know, I wouldn't know that I have it if you didn't tell me. Again, the patient occasionally will come in, they've had a pre-appointment physical, someone felt the size of their spleen was enlarged, they found out they had myelofibrosis, like, I would have known if you didn't tell me. You know, in retrospect, they may have some symptoms, but maybe or maybe not. Indeed, when we have an illness, regardless of what that illness is, there's only really two things as we think about from the medicine standpoint. How do we intervene to help or to cure if we can? There are two things we can achieve. Patients can live longer, they can live better, or both. So one aspect is, again, we think about the burden of the disease. Symptoms can be part, anemia can be part, if someone needs transfusions, if they're having pain, but part of the burden of the disease can be risk. You know, it's a bit like if I drive on the highway at 120 miles an hour, which in North Carolina is not uncommon.
What?
You know, on a side as a North Carolinian, everyone here is a frustrated NASCAR driver. Everyone. You know, so if you're on the highway, you know, and you're going like 75, they'll just blow past you. You know, it's like, you know, Dale Earnhardt, you know, slow down, buddy. Slow down. But if you're going at high speed, what you have is a risk. You might get away with it. But if a deer hops in front of you, it could be a fatal car crash. So it's a risk that is uncertain. And that's always the balance that we're doing. So first we assess what is that burden, and includes symptoms, but is not limited to symptoms. Because sometimes that risk is something you don't feel. Patients say, I feel perfectly fine. I'm like, that is wonderful, and I'm glad. But there are changes in your genes that are a major red flag that the disease is likely to change. And there's a threat that you may not feel, but it is real. You know, it's like the individual, again, that has a cholesterol of 400. They may feel perfectly fine, but their risk of having a heart attack is tremendous. So feeling fine is great, but it doesn't necessarily equate to low risk. So Naveen, this is quite the complex wheel, but it shows, again, in a very nice summary for hematologists, yes, how we think about the issues of risk. So maybe share with folks a little bit, when we're talking about risk of what exactly?
Right.
And you know, what really factors into risk?
Great. Well, I loved your analogies there as always, particularly the NASCAR. I saw the NASCAR Hall of Fame right while we were coming here, so now I understand.
It's a real thing.
Yeah, I didn't understand until I saw that.
Yes.
So a couple of factors here. Ruben set us up for this discussion. It gets into alphabet soup quickly, so we won't do that. But this wheel does tell you, we know all this stuff, we've been part of all this. But I will give you one orientation to that. So what is risk? You heard in the earlier comments, in PV and ET, for those of you facing that, perhaps most of the risk is centered around limiting or preventing bleeding and blood clotting events. I think that's very important. Symptoms and feeling better, and then unfortunately there is that smaller but serious risk of progressing to myelofibrosis AML. Now here in myelofibrosis, the stakes are higher. Because what happened is it's so heterogeneous. Oh my goodness, it's so heterogeneous. The patient Ruben described, the 54-year-old person who is going in for an elective knee surgery, you have MF, low risk, is different from the person with high risk. So let's walk through that. The initial iteration was called the IPSS, the International Prognostic Scoring Scale. That was our colleague Cervantes in Spain, 1,000 patients. This is before Jakafi ruxolitinib was developed. But what we found there is you can stratify folks in 4 and now maybe 5 or 6 different categories. Low risk, that's the patient Ruben was telling us, should mean that you don't have really any of those factors. One of them is age, 60, 65 and above. One of them is your white blood cell count at diagnosis, 25 and above. Yet another one is the Mesa symptom score. You know, what is that at baseline? How many circulating blasts you have? Ruben mentioned that to us. Those are the immature cells you have circulating around. You shouldn't have those in myelofibrosis. And then finally, the anemia. How low is your hemoglobin hematocrit? So those were the 5. They've been refined over time. They've been refined by adding the cytogenetics, the chromosomes and molecular that we talked about, how many transfusions you need, and the names get ridiculous fast. They started out with IPSS, then it was called the DIPSS or DIPS, then the DIPS plus, then yes, there's the MIPS and GIPS and whatever you want, right? So each one trying to add dynamic for D, molecular for M, you get the point. But now the latest scoring systems have so much that we're having to use calculators on the internet, and it's there. But the point is what are we trying to assess for? In myelofibrosis, you and I need to separate out quickly where you fall on those curves. Low risk should mean that your survival roughly should be measured in decades, quote unquote, depending on your other competing comorbidities and risks. So maybe there, doing no harm is a goal. Making sure you're healthy. I would also say cardiovascular health, so this is a good time to stop smoking, see your cardiologist. Maybe you don't need chemo yet. Then there's the intermediate 1 risk group, which is an active area of investigation. You have some of the risk factors to progress to AML, a decreased overall survival. Here the question is early intervention or not. Guys, some of these interventions can cause you more toxicity than what you have already. So now you're thinking about a clinical trial, or if you have high enough risk factors, maybe going to the stem cell transplant. Then you move into intermediate 2 and high risk. That's where these drug approvals are. We think that if you get to that point, either at diagnosis or later on, your risk dramatically increases for a less life expectancy, so less overall survival, yikes, and a higher chance to go to acute myeloid leukemia. There we're talking about getting onto a drug that can modify the disease, so your 4 approved JAK inhibitors, ruxolitinib, fedratinib, pacritinib, momelotinib, you know these now, or stem cell transplant, which is really the only curative modality in this disease. Ruben and I and our colleagues in the back have pioneered a lot of these clinical trials, so of course consider those. But the point here is that intermediate 2 to high risk MF, if I can be provocative here, is actually potentially an acute disease. It's a disease that needs some attention because your risk of going to leukemia or dying is much higher than those with the lower risk. Can you be lower risk, Ruben, and go to higher risk? Yes, that's the whole point of the dynamic scoring system. And so following over time, those buckets that you mentioned to us, so blood count changes, either too high or too low, physical symptoms, spleen or liver enlargement, right, because the bone marrow is failing, blast count, or the family member notices, hey, he used to do 36 holes of golf with no cart. Now he needs a cart and can only do 9 holes and is exhausted. So let's say risk in MF is similar to PV and ET. What's your risk of a blood clot? Fine. What's your risk of bleeding? But now we've added in what's your risk of going to leukemia, acute leukemia, and overall survival. That's what I want us thinking about with MF.
So very helpful, and it really sets the stage for then how do we come up with a treatment plan, both in terms of the options that are available now, and then we'll end before we take questions on, where are we going? So as I said with the patient, I have kind of 2 things really in mind. One, this issue of risk. How likely is a disease to become life-threatening? But 2, how are you affected with the disease right now? Because that burden of disease is a key factor. So we have low-risk patients, again, who have more symptoms or burden of disease. We're more likely to try therapy because we're trying to reverse that burden. Likewise, the individual that's higher risk, again, we factor in that burden as well. Sometimes not in terms of do we have therapy, but which therapy and what we're trying to achieve. Now, I saw my first patient with myelofibrosis when I was a first-year medical student, well over 30 years ago.
Can you give us the year? What year was that?
So it was a while ago. It was George Bush Sr. was still president.
Okay,
So
okay.
it was preview, Lindsay. So it was a long time ago.
And what was the temperature in Rochester, Minnesota, when you saw that?
As always, it was cold. This is pre-global warming. Global warming's been good in Minnesota. But I saw that patient with who was a hem-onc fellow at the time, Ayulu Teferi. And it was a lady who came to see us from Venezuela. And she had really severe myelofibrosis. And the disease, was very hard on her, and she passed away from complications of, at that point, splenectomy, which at that point in time we had nothing to help enlarge spleens. Her spleen was massive. She could hardly stand right to push the stroller with her two twin girls. And she had a splenectomy, and she died of complications of splenectomy 3 days after the surgery. So this was very traumatic, of course, to witness. It was catastrophic. I mean, the husband was there, the two kids. It was just horrible. And that's one of the things that really got me interested to see, how do we make a difference in this? Because this is terrible. Now, up through 2005, Ayulu Teferi, myself, colleagues at MD Anderson, and a much smaller group than exists now, were trying to find better therapies for myelofibrosis. And in short, we didn't have a lot of success. In large part because we did not have some of the biological clues that Dr. Elf discussed earlier. The discovery of the JAK2 mutation was a key first step. It didn't tell us the whole story, but it was an important step to, one, have therapies that could target that, and two, get more people involved in the fight against myelofibrosis. More investment of companies thinking, well, now we have a target, maybe it's worthwhile trying to develop a drug for this. So we now have 4 approved JAK inhibitors that really flowed from that discovery. And they've all made an important impact: ruxolitinib, fedratinib, pacritinib, and momelotinib, as you see, from 2011 through 2023. And we'll get into these in a little bit as we discuss therapy. So let's talk a little bit about how we do treatment planning. So one, this looks a bit like the Tokyo subway map, I realize, in terms of, this is a bit how physicians, in a very non-patient friendly way, this is really for physicians, but kind of guide a bit of a decision tree of how we think about therapies. We have treatment guidelines for almost every cancer in the United States. And I and others were involved in developing these for MPNs. And I'd like to describe them a little bit, that they are around this art and the science of medicine. The science are what are the options to potentially choose from. Because again, if I had some crazy idea to give, beet juice for myelofibrosis, that might be nice, but I may not have any evidence for that. And again, that really would need to be tested. Not to say it couldn't be helpful, but again, is there any proof that it's helpful? The art of medicine is choosing which of the things of which we have science around that really applies to that individual. So people say, boy, AI is going to take over for doctors. Nonsense. AI will be helpful in all sorts of different ways. People who think that AI is going to take over what people do, it is not, because it does not really substitute judgment, heart, emotion, or experience. But it will be a very helpful tool to help people be more effective. It may make clinical notes much easier to do, and may give us more information from scans. It may help us bring together 40 pieces of information where we used to try to do that kind of off the cuff. So it'll be super helpful, but it's not going to replace anybody. I think we'll just be doing different things. We'll probably, hopefully, be more effective. So Naveen, walk them through a little bit.
Sure.
People assess risk. Where do we go from there?
So we talked about risk. I like this slide because now we're talking about the higher risk, which we can define for this conversation if you're in this intermediate to higher risk by some of these scoring scales. So I want to walk you through this flow chart because when you look at it, it looks kind of crazy is the word I would like to describe this and the footnote. So three things to make this a lot more reasonable. The first thing is the symptom scale. This is something, he's too modest. The reason why he's the father of the modern era of what we're doing is because of a number of things. The first comment, you're too modest. It wasn't for lack of trying before the JAK inhibitor era. You and others tried dozens of drugs. You borrowed from autoimmune diseases, inflammatory, antiparasitic, solid tumors. So your work is in the Hall of Fame already. But a second thing that many of you may not know is that it was Ruben and his group, Robin Scherber, Holly, and all of our other friends, who not only invented the MPN symptom burden scale that we use now in every patient and every visit, but it's actually held up by the FDA and all the regulatory agencies as the quintessential paradigm for all cancers to include your voice, the patient's voice, PRO, patient-reported outcomes. So I just want to give a round of applause to Ruben for that discovery.
It clearly a team effort, but making me sound old. But,
Well,
but please.
you did tell us the year that you saw that first patient, so I put you on the record there.
Yeah.
So our modest host here won't tell you, but that's the first step that we use in the clinic is this scale. And what's pretty cool what you've done, how many languages have you translated into? 50 languages by now?
So I think it's at 20-something languages, but we have data now in well over 10,000 patients in 90 different countries.
Okay, that's amazing. So the iterations are getting more and more streamlined and efficient over time. Maybe now we're to 7 symptoms, 10 and 7 symptoms, but that's the first.
One brief digression,
Yeah.
but it's relevant. As we look at patients around the world, culture has an impact on how severe an individual rates their symptoms, but not the ranking. So if we look at the ranking of symptoms, of how people are affected by ET, PV, and MF, whether you're in Madagascar, Australia, Malta, or the US, the ranking of symptoms is almost exactly the same.
Wow.
So there's a biological truth that links to the biology between symptoms across cultures, but then there are cultural impacts in terms of severity. So I've often offered to folks, there is a PhD in anthropology out there for whoever wants it, and has the time to really kind of do the anthropological
That's cool.
assessments on this.
That's cool. So that's the first part, is doing this sort of Mesa symptom burden scale. So you understand your patient, what they're going through. That helps you with the goals of care, you and I, when we're at the bedside. The second branch point is your platelets. Interestingly, we didn't talk about that much. Maybe more than the biological aspect, it's really the practical aspect, because that helps me to decide among those 4 JAK inhibitors which one you may qualify and which one you may not. And then the third branch point should be, are you a transplant candidate or not? 20 years ago, maybe that was more simple, age or older or younger, but now our group at Anderson, Fred Hutch, many of the sites around the country, we're routinely transplanting folks in their 70s, mid-70s even. So it's not age, it's your performance status, your comorbidity scale, how you're doing, what's your donor status, insurance, et cetera, et cetera. One of the great steps, and our group is really proud of this, is that Medicare, Medicaid used to not allow transplants for patients with MF until it went all the way to AML. But now we've lobbied and convinced that, so that's something important. So what's your symptom scale? What's your mutations? What's your platelets? Are you transplant eligible or not? That's part one. Now we go to the second part here, which is, what are you going to do for treatment? If you're not a clinical trial candidate, okay, you have your JAK inhibitors. We mentioned those. Ruxolitinib, first in class, been around now for 15 years plus. JAK1, JAK2 inhibitor, twice-a-day drug, first in class. Ruben, as well as our colleagues Serge Verstofsek, Claire Harrison, and others pioneered. That's New England Journal 15 years ago. The second drug, so that was there. The second drug is fedratinib. Fedratinib shown in the Jakarta studies, 2019 August, which for some reason was 6 months before the COVID pandemic. and then so on and so forth, the pacritinib and the
Completely
momelotinib.
unrelated. Completely unrelated. Yeah.
So the Rux and the fedratinib are important because their approvals were platelets 50 and above. That's why the platelets, okay? So those two are FDA approved, they're available. You have to know about the black box warnings. Fedratinib, you have to watch out for thiamine deficiency and encephalopathy. But what's important is the pacritinib and momelotinib, which have only been available to you just in the last few years, those can be given, and they were tested in patients with platelets less than 50. And I think that's the branch point. Why does the platelets matter? Pacritinib specifically has an accelerated approval team for platelets less than 50, at least in the front line. When you get to the later lines, you know, there's a little bit more generous use. And then the momelotinib, Ruben led that study. Actually, you included patients 25 and above, which was very smart. So now you have options, even if you have what we call cytopenic MF at diagnosis. So you have too much anemia, too much thrombocytopenia, so low hemoglobin, low platelets. Maybe you don't have to necessarily reach for the Rux and the fedratinib. You have two more options. Ruben, let me pause there to see what you want to add as we go through the flow chart.
So I think where we stand right now is, again, we have 4 approved agents. They all have an important role, and there's aspects in terms of which drugs we choose first based on how an individual's doing, and particularly their blood counts.
Right.
And then if one of those therapies doesn't help, do we use one of the other ones that are in reserve based on how the individual has evolved? Now, as a final step, let's talk a little bit about kind of where we're going, and then we'll take some questions. So one, let me highlight that absolutely everything that has been accomplished to date and everything that's accomplished in the future really only occurs because of the generosity of individuals being willing to participate in clinical trials. Clinical trials are really how we evaluate whether the therapy is better than what we are doing currently. It's a very structured way of, again, giving you a therapy. We know what you're getting. You know, sometimes there may be more than one option that you're getting that we are blinded from, so that we don't, you know, kind of put our thumb on the scale in terms of what the outcome is. But this is how we learn and make progress. That's why we have 4 approved drugs and why we try to move forward. So again, a plug for, you know, if your physician, you know, offers a clinical trial, to at least consider whether it's something that might be a good option for you.
Including even in the frontline setting,
Good.
even in the first treatment.
Correct. You know, until we have a perfect therapy that cures you with no toxicity in a rapid way, we're not where we want to be.
That's right.
You know, so again, we have diseases, childhood acute lymphocytic leukemia. We have high cure rates, but again, there's still long-term side effects and toxicity. So we have clinical trials to see, again, can we do that in a safer way so that kids are not impacted longer? So we continually want to make everything we're doing better and better and better.
That's it.
You know, we are in the jobs of putting ourselves out of business. You know, and again, if we get this solved, you know, Naveen and I, we could do Broadway. You know, we could totally, we could totally do some sort of Netflix special. I mean, we have
I'll talk to
options.
my agent, Ruben. I
Yeah.
told you multiple times, not to me directly.
We have options. So we are trying to put ourselves out of the MPN business. So again, we can get on to other things. That's right. So let's talk a little bit about clinical trials. So I'll share with you, there was an era in patient meetings where we could stand up here
Yeah.
and we could just off the cuff tell you about every clinical trial going on in the U.S. because there were 3. You know, we could tell you there was, you know, there's this trial in Houston. You had to fly to Houston. You had to go to Mount Sinai. You had to come to Mayo Clinic. And the good news is that as a team effort, there are a lot of clinical trials, which is really exciting. And I view them, again, that they're really testing in parallel to see which of these is really going to make an impact. Now, sometimes for some folks, depending upon how you look at this, it can be distressing. Boy, you know, I want to be on all of them because, you know, I want to be on the one that works. The thing to be reassured by is as clinical trials progress, if there is a home run, that information gets spread very quickly. And the ability to pivot from a few people being treated with something, if it is miraculous, the availability of that can really be quite rapid if that occurs. And we've had examples of that. The progress that we're making has still been more incremental. It's still been slower, so again, it's more measured. Yep. But if that home run occurs, I could see really within months going from being few to, if we have a home run,
that's right.
One, people will know, people like Ann will tell you, and two, the mechanism for going for clinical trials at one site to clinical trials across the country would expand.
That's right.
So, rather than go through these drugs one by one, because it is a significant number, why don't you talk a little bit about some of the themes where new therapies are going?
Oh, great.
We're inhibiting JAK2.
Great.
As well as maybe just throw out a couple examples out there.
Perfect.
But realizing that, again, we're talking maybe 30, 40 trials kind of going on that are significant.
Well, that's exciting. So, as always, you inspire me every time we talk. And so this just reignited me because, when I got into the field, as you know, just a few years after you, just a few years after. So JAK2 was 2005. I was at that time at Johns Hopkins, and there was a buzz, maybe for the first time, at least in this new modern era. And so where I made my name is exactly what Ruben's talking about. I wanted to do the new therapies, the clinical trials that may be expanding from JAK inhibitor monotherapy. So let's talk about those categories or buckets, and that's where all these letters and numbers fit in there. Category 1, I've asked the question, Lindsay had mentioned it earlier, can we go for disease modification beyond the spleen and symptoms where we're affecting your overall survival and we're able to prevent this thing from going to AML? So that first category is adding a second drug to the JAK inhibitor that you're already on. So you're already on the ruxolitinib, for example. And those drugs are interesting. We originally borrowed from AML, myelodysplastic syndrome, all these others. And what we call that is add-on therapy. So you're having some benefit from your JAK inhibitor. Let's add on a second drug. The second category is where we start with 2 drugs from the beginning. And one of you astutely asked earlier, what about combination therapy? The reason why Ruben and I haven't mentioned that yet, it's not yet standard of care. So we're aspiring to that. We're hoping for that. But I owe you, and I still haven't done it yet, I have to show you that toxicity, the side effects, isn't worse than what you started out with, that it actually modifies your disease and it actually improves you. BCL-XL inhibition, bromodomain inhibition, XPO1, all these categories, MDM2. The final aspect is, can you do a new drug even without the JAK inhibitor? So you've already had the JAK inhibitor, or maybe you don't qualify. And that's where Dr. Elf and her colleagues are helping us look at the biology of the disease, identifying new pathways. Isn't it interesting? Perhaps I'll use the example of breast cancer or testicular cancer. A lot more is known, right, than about ours. And so we don't have our own ribbon, we don't have our own race, but we have Ann and others who are advocating for us. And so I want to put that out there as something very exciting. So that's why scientific research and support is so important. We need to find new pathways. Ruben, the final and fourth category is something near and dear to our heart, which is improving the anemia, the low hemoglobin that many of you suffer from, either from the treatments themselves or the disease, or as the darn thing progresses. And there we have a host of drugs that are trying to aim to just hit the anemia and bring that up, either as part of JAK inhibition or as its own category. So maybe let's put that out there. So adding on to a JAK inhibitor, starting out with the combination, a brand new novel therapy in the relapse setting, and then this final thing of anemia. Those are the 4 buckets for all of these things where they fit in.
Wonderful. Well, it frames the issue as well as I seem to be the only one getting more gray hair as we.
Is this AI generator? This
yeah.
really?
But let's take some questions, as well as, again, very much happy to answer a question as it relates to any of the specific clinical trials going on. But again, it's become such a list that, again, best held in the category of hopeful, but still, people say, boy, which of those is going to be the next approved therapy? I cannot predict.
It's amazing. Questions?
And Ann, let's tell folks, you can look these up online now a lot
Yes.
easier. Clinicaltrials.gov, that's a
They're
sort of
on our
nonpartisan website. Your
Yep.
website,
Clinical doc.
LLS, there's so many
Yep.
other websites.
Yep. Any questions for these 2 lovely gentlemen that are going to ride off into the sunset and become nothing? Oh, okay.
You talked about leaking cells. What blood test is that picked up in? Is it a CBC or some other blood test?
Yes. So the CBC, the machine gives you a differential. So typically what this falls under is under the differential of white blood cells. When you get your CBC, you have a variety of information. You have a variety of parameters that really are around the red blood cells or anemia, hemoglobin, hematocrit. There's several that really are describing the red blood cells in several ways. You have the platelets, which pretty much has kind of a singular value. But then you have a total white blood cell number, and there are multiple types of white blood cells because they have different roles in infections and inflammation. But then there's other cells that normally aren't there to begin with. So typically, a CBC is run by a machine, but then it flags for someone to take a closer look at it visually if there are additional cells there that normally are not there. So that's where they fall. So normally they're not there, and they don't get reported. They only get reported if they're seen. Myelocytes, metamyelocytes, blasts. And now as the machines have gotten more sophisticated, the machines will comment on some of those.
Right.
But that, is one of the reasons to say, boy, if I have the CBC, if I felt the spleen, if I've asked a person how they felt, that tells me a lot about how stable or not stable they are. Because to some degree, MPNs tend to be stable and then change. So really we're looking for that change.
That was a good point because I can't remember who did the study, or the survey, asking patients what they hoped to get from their physicians. And then there was another questionnaire that was sent to MPN physicians and what they look at. And very few said how they feel. And so I'm glad you said that, to ask the patient how they feel,
Right.
Any other questions at this time? And keep in mind also that you'll have plenty of time to ask. Jot down any questions if you don't feel comfortable at this point, but you'll have plenty of time to ask later also. Any right now?
And also to mention, we then take a deep dive into the issue of transplant after
Yes.
lunch as well.
Yes, which will be fantastic. Dr. Grunwald and Dr. Jane will be up here at that time, and it'll be very, very interesting. Now, this will be my before and after. Right, sister? We talk about it all the time. Anyway, thank you both very, very much. We so
Thank
appreciate
you.
it.
Thank you.